So I'll start. I'm hoping that everybody can hear me. So thank you very much for that introduction, Bruce. I've been working with Bruce now for the last, since 2007 we met, and Bruce was my mentor, prescribing mentor, because when I moved from the UK, I had to do the prescribing course in New Zealand to be able to register with Nursing Council. I've been a prescriber in the UK since 1999. So my background, as Bruce says, is paediatric. I was a paediatric nurse trained at Great Ormond Street, which I feel very proud to have trained there. It's the second children's hospital ever in the world, built in 1852 by a very eminent paediatrician called Charles West, who apparently loved children, not in a weird way, but also argued with Florence Nightingale about the need for a children's hospital in the area in the East End of London. And Florence Nightingale was very opposed to that because she felt that children should always be with their mothers. And so one of the premises of Great Ormond Street was that children and mothers would always be able to stay with children when they were in hospital. Mildred Creek, famous child psychiatrist, the end of the 1800s, beginning of the 1900s, furthered that attachment and need for the emotional care of children in hospitals. So I won't give you a history lesson, any more of a history lesson, and we'll go into the topic straight away. Pediatrics.
A short comment there, because in New Zealand up until maybe 20 years ago, mothers weren't allowed in hospital with their children. And I remember when I was a medical student going to sort of like an encounter group, and people were talking about childhood traumas, and the most common one was having been in hospital and your parents not being able to see you. It really was very traumatic. So I think
and that was probably, Bruce, because children's reactions, you know, if anybody's ever studied detachment theory and what happens to children when their significant other is removed and how they go through different attachment denial stages, which were very well described by John Bowlby in the 50s. People thought prior to that attachment theory that it was cruel to keep the children in hospital and let the parents visit. So it's really interesting how emotional and mental health of childhood has changed over the years.
And that was because when the parents did turn up, the kids would get upset and people
exactly. They would scream and shout and carry on.
So exactly. Sorry about that, but I thought that would be a little interesting historical point there.
So just to plug for pediatrics, children aren't small adults and shouldn't be treated as such. That I am married to a pediatrician, so we've worked all over the world doing various things. And I was just talking to him now. If you are interested in pediatrics, you can get general pediatrics, all the training you need here if you want to be a general pediatrician. But if you want to specialize in pediatrics, you probably will have to go to one of the bigger population centers, because we are a very small country, and although we see lots of different conditions, if you want to specialize, you'll probably have to go to somewhere like Melbourne or Sydney, or, you know, further afield to Great Ormond Street. And I plug Great Ormond Street. It was a wonderful place to train at. And also I met many celebrities because it was the children's hospital. Enough. I am going to continue now with some teaching. So, and now here we go. So these are the topics. So I'm hoping that some of you will have, or most of you will have watched the 6-week webinar. I'm going to talk mainly around the questions that were generated from that webinar a month ago before lockdown. Then I'm going to talk a bit about managing seborrheic atopic eczema in the young child. then spotting the sick child, 3-minute toolkit, and then we'll have a bit of a question and answer session. So Bruce is going to monitor the chat function. If you've got any burning questions, please ask them in the chat function, and then Bruce can stop me and we can discuss what your queries are. So topic 1, the 6-week check. And as I said, I've just picked these 5 topics from that 6-week check webinar because firstly, the baseline for growth is critical in the 6-week check. It's the time when a baby should have come back to its birth weight. We need to know that it's growing, that it's feeding well, because growth is so vitally important in terms of pediatrics, in terms of an indicator of illness and wellness. Vitamin D was a really debated topic. People didn't know the importance of vitamin D. Cameron Grant, our professor, has done many studies in South Auckland around vitamin D levels, and that we've got particularly low levels of vitamin D in our Māori and Pacifica children. The red reflex, that generated a lot of queries about how the red reflex is tested and the implications of not seeing a red reflex, what it should look like. Maternal mental health, which I know Bruce will completely support me on, is so vitally important. When you think that the first 1,000 days are setting a child up for the rest of its life in terms of physical and mental health, maternal mental health, because it's usually and hopefully the mother who is the person providing the care in those early months, is utterly vital. And that the mother and the child should be seen as a dyad, certainly in the first 6 months. And child protection. And I want to emphasize how important that is, because we as a country are not doing very well in terms of protecting our children. And of course, immunizations. So here we are. So sorry, I missed this slide for a virtual chocolate fish, and now I've given you a clue. I want you to think about what the 3 most important evidence-based global initiatives are that have saved infants and children's lives. So if you wouldn't mind putting it onto the chat function. Sorry? Oh. If you wouldn't mind putting it onto the chat function, and we can have the answer at the end of this tutorial. So I've put this as there's somebody's left them a microphone on. Would you mind just checking that your microphone's off? Growth. I put this slide in just to demonstrate growth in terms of how important not just the head circumference is, but also the length and the weight is at the 6-week check. What I always do is, if the well child providers have done their 6-week check, looking at the physical growth, I'll transfer their information into our MedTech growth charts so that we don't have to duplicate the tasks that are done at the 6-week check. The head circumference is really important, because if you don't check it at this stage, and then come back, the child comes back when they're 5-6 months and there's issues in terms of their neurological development, and you haven't got a baseline head circumference, it doesn't look very good when you're trying to refer them to pediatrics. But also it's best practice to make sure we've got those early growth parameters. So parents are often concerned about fontanelles, and if they're closed too early, what will happen? The baby's brain won't grow. And we can reassure parents that unless a baby's got a condition known as craniostenosis, which is when the sutures have fused early, then if the fontanelles are closed early, and the posterior fontanelle, the rough guideline is that it closes at about 6 weeks. The anterior fontanelle is anywhere between 18 months and 2 years, but very often they close, or they feel like they've closed earlier than that. But it's the sutures that are important to make sure that the brain continues to grow, that the head continues to grow. So you can reassure parents that if the fontanelles have look like they've closed, the head will still be growing. Vitamin D, as I was saying before, was recommended by the Ministry of, it is recommended by the Ministry of Health. There's a sheet called Vitamin D and Your Pregnancy that is available on the Ministry of Health website, and the recommendations are, because we know from the studies that certainly darker skinned infants are more at risk of being vitamin D deficient. Women who cover up during pregnancy, so women who wear headscarves, etc., are more likely to be vitamin D deficient because they're not getting the exposure to the sun. So the high risk for vitamin D deficiency is darker skin and not being exposed, if your mother's not being exposed during pregnancy, her levels are going to be lower, and if you breastfed. So there was concerns that Vitadol C, which had vitamin A, C and D, would lead to hypervitaminosis A because the levels were concerning. There wasn't enough information in terms of vitamin A for infants. So in January 2019, Pharmac made Korea, which is just the vitamin D supplement, available so that we can give it to all infants from 6 weeks old, breastfed infants, particularly those whose mothers are Mari, Pacifica, or covered up for some reason. So we have started this with all of our infants get their Courier drops. It's 1 drop on a nipple or dropped into the mouth daily. And the evidence probably should be that they get these drops until they're at least a year, maybe 2 years. Now, the reason we need to give them in New Zealand is to do with the tilt of the sun in the winter, particularly in the winter months, because of the tilt of the sun and the way that the planet, our planet is, means that we don't get enough UVB rays, which is the main way that we produce vitamin D. But the other really important thing in terms of our population, Mari and Pacifica particularly, is that vitamin D has been shown to play a role in reducing respiratory tract infections. And we are known as the pneumonia capital of the world, of the developed world, in terms of childhood pneumonias. So it might be a good insurance policy to see if by making sure we're supplementing our Mari and Pacifica, we can bring down some of those awful rates of respiratory tract infections.
Karen, I have a comment about that. It's interesting. Vitamin D may work in adults to prevent respiratory infections. I've been thinking of making a gem on it, but I thought it would cause a massive run on the nationwide supply of vitamin D. If you're truly vitamin D deficient, it makes a big difference. If you're not, the numbers needed to treat are about 20, and it's better to take a little bit every day. So we'll just let the audience know that as a little giveaway. Probably 1,000 milligrams, I think it is. I'm not sure.
1,000 international units. Although, yeah,
That's
it's 1,000 international units which you can buy from the pharmacy.
Yep.
And I take 2,000 because I was given that advice, and I can't remember where that advice was from. Probably I'm overdosing myself on it, but it's not going to do it's not going to do the same amount of harm vitamin D.
It doesn't seem to have any toxic levels.
No.
And good for your bones, Karen.
Good for my bones, that's correct.
Yeah. Okay.
So what we're probably going to do is, because I work with an associate professor at Massey who's very key, a nutritionist who's very interested in vitamin D, and we're going to be looking at our children and doing a prospective case control maybe study around, you know, the children that we've been giving the vitamin D, or the infants we've been giving the vitamin D to, and what happens in terms of their respiratory tract infections. Because you know, and I know, Bruce, that we have extraordinary levels of respiratory infection in our under fives in Manurewa. Huge burden on the health services in terms of having to send them into hospital, because you don't know which ones are going to develop pneumonia or get sicker when they come to see us in primary care.
The other side is that they don't all need antibiotics, because from the Growing Up in New Zealand study, by the time you're 95 or 98% of New Zealand children have had an antibiotic. And I'd have to say, while we've got a lot of, they're mainly viral illnesses, is just be careful with the antibiotics. So just trying to get that measure across, because they're not universally safe, and they do contribute to the resistance pool. So just be judicious. And remember, antibiotics for respiratory things are rarely mandatory unless you've truly got pneumonia. They're often discretionary. So a little take-home point there.
Definitely. And also, you know, you're going to maybe do more harm with infants, because you may be going to give them diarrhea if you give them antibiotics when they don't actually need them.
Yeah.
So the red reflex, this created a lot of questions and then further emails after the webinar. So I thought I would I would talk about this for people who, well, for you people. So for the red reflex, the room light should be dimmed or off. The ophthalmoscope setting should be bright and set to the largest white light circle. The lens should be set to 0 or to the prescription of the examiner if you are short-sighted or long-sighted, and if they've removed their glasses. And the infant can be positioned as these two photos demonstrate. So the first photo, as I look on the left, the mum's got her hand under the baby's nappy and then in front of the chest. But I prefer the position of the baby on the right, with the baby over the shoulder, because just anecdotally, I think they open their eyes more. Now, there is a maneuver called the doll's eye phenomenon, where if the infant won't open its eyes, you can just gently move its head from side to side and it will open its eyes. Then it's the doll's eye phenomenon.
Karen, can I make a comment here, just to give it some context? The reason why Karen's explaining this is it's very hard to get a young baby to open their eyes. And you do this examination, and it's very hard to do this thing. That's why you have to go through this. And what you're looking for is, if you can't see a red reflex, there's likely a cataract there or a tumor. And
so I'm going to go into that, Bruce.
But, okay, just wanted to get some context. I just thought people need to know why we're doing it.
Right. Sorry. Yeah, I'm hoping that they will have all watched the because these are.
I wouldn't assume that.
No, you probably haven't. So okay, so I'll go back a step.
Yeah.
If you've got a very short period of time in terms of doing a 6-week check, and you want to do, for the physical examination, the 4 most important points to check on a baby, then you're going to look for that, because these are all time sensitive in terms of long-term sequelae and problems for the infant if you don't get this right and you don't refer them. So the red reflex is the first thing. So the second thing is the heart examination and the femoral pulses. The third thing is the hips, the Ortolani and Barlow sign. And then the fourth thing, if it's a little boy, is the testes, checking the testes. So there are the they're the 4 things that if I'm doing a very perfunctory, quick 6-week check, because I haven't got time, I'm going to be doing in terms of physical exam. So back to the eye examination, as Bruce says, it's all about setting the baby up so that you can actually see the retina, and you stand an arm's length away, you look through the ophthalmoscope, and hopefully you'll be able to see both eyes, so you can compare the back of the eye, the right and the left. And what you want to see is a beautiful red reflex. So now, these are the most worrying conditions that you don't want to pick up. Retinoblastoma. Now you can see the baby, right, the baby's eye, the top picture, the baby's right eye is the eye with the retinoblastoma. The left eye is a beautiful red reflex, and that's what you should see when you look at the back of the eyes. Brown eyes are more difficult to get that lovely red colour. They are more of a browny red colour. But the retinoblastoma, that's the leukorrhea you would see, and what it is a tumour that's obscuring the retina. Now that's an absolute medical emergency. I certainly know a community paediatrician in the UK whose baby was born with a retinoblastoma, and he picked it up from photographs when you know, you do the flash and the photographs show the red eyes. He saw this, that one eye was showed the red eye and the other eye had this leukorrhea in it, was able to get onto it straight away. So it's always worth asking a parent if they've seen this red eye reflex when they've taken pictures. Now the picture on the right at the top is ptosis. Now a ptosis isn't an issue unless it's covering the pupil, which that ptosis on the right is doing, and in which case that needs urgent referral. Congenital cataracts. So I've got a statistic here. Every week delay in cataract removal before the age of 14 weeks equates to the loss of 1 line of visual acuity on a Snellen chart. So congenital cataracts is really what we're looking for, and they are very often missed. I've got the statistics here. The incidence of congenital cataract in the UK is 2.49 per 10,000 by age 1 year, and because of delayed diagnosis, this rises to 3.46 per 10,000 population by aged 15 years. So imagine if you don't pick it up, and then the sequelae of the child becoming visually impaired because of it, especially if they're bilateral.
Karen, I thought I'll tell my story now about the nurse. When I was a 4th-year student, I went and worked as an orderly in Western Australia, and I was essentially a med student there. And one of the nurses told me that when she was 16, she did an eye test, and she covered up one eye and she could see the eye chart. She covered the other and she was completely blind. And the first time, I wasn't taught about congenital cataracts at medical school, but I've since learned they're an absolute emergency, which what
they are.
Examination so important, and it is really difficult to see there. And I think it's great the way you're showing. Just got a question here. Can retinoblastomas present later, or will they always be present at 6 weeks if the baby?
No, they can present later.
Okay, good.
Yeah, this particular baby was this particular baby was born with it, but no, they can present. They can present throughout childhood, and they are again a medical emergency. They're nasty.
Yeah, so and they do cataract surgery, don't they? They put a lens in.
Yeah, and chemotherapy, etc., etc.
Oh, for retinoblastoma, I was thinking for the cataract.
Oh, for cataracts, yes, and they put a lens in, and then they have to change the lenses as the child grows. But it's an interesting fact, isn't it? How they lose that vision, which is you know, you can't sit. I've only ever had 2 since I've been at Greenstone. I've only ever sent 2 babies to Green Lane, and fortunately neither of them had congenital cataracts. Other cues for visual development is you ask the parent if the baby's smiling, and at 6 weeks you should be able to engage the baby's face to look at you and get them to follow your face through 90 degrees. Some babies you can get them to follow you through 180 degrees, so they're looking at you. Now that's a really good sign, and also to ask the parents if they're smiling, because that is a reflex from looking at your face and development, neurological development. Anything else about eyes? Watch the 6-week check webinar if you're interested in more around the 6-week check, the physical aspects for the baby. Immunisations are absolutely vital. I'm sure we all know that now, and we're all desperate for a COVID-19 immunisation to come along. Okay, so the next slide is assessing the mother's mood, and I know Bruce will support me in this. It's absolutely critical that we assess the woman and make sure that all is well. Now, you can perfunctorily say to a woman, how are things? And they'll go, oh, fine. It's giving them the PHQ-9 or the Edinburgh Postnatal Depression Scale and asking them to fill it in. That gives you more of an insight into actually what their mood is. Particularly that question on the PHQ-9, how are you finding things? Not difficult at all, somewhat difficult, very difficult, extremely difficult. I've had women score a 3 on a PHQ-9, and then they've circled as somewhat difficult, and you ask a bit more about what's happening, and they burst into tears and things are really difficult. So it's a great mood assessment. It's not a screening tool, but it's a great mood assessment, and it's I think it should be mandatory that every baby's mother gets this done at the 6-week check. I think we're quite unusual at Greenstone. I'm hoping that more practices are doing it around the country.
Yeah, I mean, it's so important. It's one situation where screening is recommended as opposed to case finding. So even if you think the patient is coping very well, it's probably mandatory to actually do a screen, either the Edinburgh or the PHQ-9, to get an idea of how they're doing, because the consequences are so great for the person and for the children. If a mother remains depressed, the outcomes the child has a much more bumpy life. But the other thing is to think about from the Growing Up in New Zealand study, the group of postnatal depressed women changes as you go through. It's not the same group. So somebody who's depressed at 6 weeks may not be depressed at 3 months. There may be a different group. The other thing, and it's a little bit lower for the fathers, but the fathers also get depressed. This is a major biopsychosocial event in a family. And for those of you who don't have children, you may underestimate that. But if and when you have children, you realize what a force du jour this is. It's pretty big. And if you don't have a lot of resources to cope with it, you can be flattened by the tsunami of childbirth. So it's something to think about. And I would say it's crucial to pick up postnatal depression. I know you have pretty well 100% rate of screening these women who've had babies, and I think that's to be commended. And to get on with talk therapy, not necessarily drug therapy. If you're really worried, Karen and I had a patient the other day, she called in the maternal mental health team, because under lockdown, the 3 people I've seen with the most difficult situation have been solo mothers with boy children who are playing up and being stuck at home without any resources. And one of them I got Karen to call, and she got maternal mental health. So these are particularly difficult times for young parents, particularly if they're doing child rearing on their own. Don't underestimate the stress of that.
Thank you, Bruce.
Question here, a bit after the topic, but do you know what the rates of craniosynostosis are in New Zealand?
Craniostenosis? No, I knew somebody would ask me that. It's very rare.
Yeah.
So one of the things I would say is, I was just discussing this with Simon before the webinar, you know, whether I say to you guys, if you want to be pediatricians, go and get yourself some experience overseas, because Well, if you go to Great Ormond Street, you see these things, you know. And I remember, Bruce, you saying to me one time when I was doing my prescribing practicum, Karen, you always look for unicorns. And I couldn't help that, because I've been exposed to so many unicorns at Great Ormond Street that they would never be off my list of differentials when I'm thinking about what a baby or what a child might have. So, yeah, just a little... I've seen a baby with craniostenosis. They have to split, they have to surgically.
Karen, can I make a plug for primary care pediatrics? You're suggesting everyone goes overseas to train, but I think actually, if you really like children and you like dealing with healthy kids, then primary care offers a lot.
No,
a friend of mine was in the pediatric scheme, and she found it just a bit hard work seeing very sick kids all the time. And she actually found in general practice, she actually enjoyed seeing basically well kids. You'll have a handful of very weird syndromes. All of us have a handful of genetic or, kids with a lot of problems, but it's a lot of fun seeing kids in primary.
It is.
You learn how to... I've got a question here, Karen.
Yeah.
What are some resources, services you suggest for women who have low mood postnatally? Are there some specific for the postnatal period that you recommend to patients?
Yes, so there's a website called Purple Crying. What I would suggest, and I'm going to go on to this now so we can talk about that now, is, Bruce, in our practice, we have Larissa, right? Yeah. Bruce alluded to talking therapies. With women with postnatal depression or with low mood, because you can't really diagnose it on that 6-week check. It might be low mood. As Bruce says, it's a major life event, having a baby. And talking therapy, so what I used to do, I used to be a health visitor in the UK, which is the public health practitioner, would be 6 weeks of talking therapy. So see the woman every week just to talk through, let her talk what's going on in her life. Now, we're fortunate in Manurewa. We have a respite service just round the corner. It used to be just for serious maternal mental health issues, but they've opened it up for women with distress. And this is basically women who are going through emotional distress if they don't have the social support, if they are finding dealing with a new baby quite difficult. And I often find women who have been in high-powered jobs, who are used to being in control of things, maybe women who've had to have IVF to be able to get the baby, they are the ones that often crash because they're not in control at all. You know, you've got to have a flexibility around what you do in those early weeks, because the baby is the focus of your life and everything else goes out of the window. So it's helping women to find strategies to look after themselves. So that picture of the nail polish, I always say to the woman, you know, just once a day, if you can, give the baby to the partner, mother, etc., and do something for yourself, and don't feel guilty about it, because that's the other thing that comes with having a baby, massive maternal guilt. And then the most important thing is sleep, and I think that's where our maternal respite centre is wonderful, is because I can send somebody around there to sleep for the day or sleep for the night, and the people will there just look after the baby and cook and look after the mother. So they'll cook the mother a meal, and sometimes that's all that people need. They're not going to go downward spiral into complete postnatal depression. And as Bruce says, you would never give pills at the first consult for this. You would never give antidepressants, because you need to try all those other things first. Often depression is not true depression, it's an emotional reaction. Okay, so sleep is vastly important. There's nothing worse than sleep deprivation, which happens when you have a baby. It is used as a torture in countries around the world, sleep deprivation. So recognition that a woman needs sleep. this Calm app is fantastic. You can have free sessions. There are sections where you have to pay, but you can have free sessions. So I always get the woman to download the Calm app onto their phone. Is that okay? Any other questions around that? Well-being.
I was just going to say, so you mentioned purple crying, and I just looked that up. That looks good. The other one, if somebody does, you know, they should be talking to their family doctor, but you may like to know about a new website, a CBT website in New Zealand called Just a Thought. Just put Just a Thought into the web browser and you'll get that. It's a New Zealand adjusted one or shaped for New Zealand, and it's free, and it will help people who've got various problems with their mood. It's not aimed at postnatal, but there's something there for everybody, and that's online CBT, which we know if people do it and finish it, they do very well. Like anything in healthcare, if people follow instructions. Would you like to say a word about purple crying, Karen, maybe?
Yeah, no, I haven't been on it for a while. I just know that it's an excellent website. And the other thing that I nearly forgot was that involve the practice nurse. We've got a practice nurse, Larissa, who is a special interest in pregnant women and with infants, and she becomes involved with this. She'll ring the parent, she'll ring the mother up, she'll see the mother, she'll do the talking therapy with the mother, and she'll do the referrals to the maternal respite centre. So use your nurses, use the nurses. Don't think you have to do everything in terms of looking after maternal mental health. Please do, and the more, the better we train the nurses, the better outcomes for our patients in primary care. I think we are, certainly at Greenstone, our nurses are very well used, but it is a deficit, I think, in terms of how we don't connect with Bunket or with the Wellchild Tamariki Aura providers. We all work in our separate bubbles. If you can connect with all of the resources that are out there for women, rather than think that you have to do these things yourself. Do you want to say anything, Bruce?
Just one more question, then maybe we move on. When would you refer a mother to maternal mental health services?
Right. Okay. So if somebody's crying constantly, if you're concerned that they're not able to rally support, the resources, like the woman that we were talking about before, Bruce, she was on her own, a solo mum. She was in her bubble. She had divorced her family at age 16, so she had no maternal support, and her partner didn't want to be her partner anymore. So she was incredibly vulnerable. She was also quite young. She was 24, and she had a 15-month-old and a 3-month-old, and she was in lockdown. And she wouldn't stop crying. I was on the phone for an hour and a half, and she cried for an hour and a half. That was a scenario where I thought, this is beyond what I should be doing. I need to involve maternal mental health. Now, I'm going to talk to you about the symptoms and signs of life-threatening mental health conditions in the postnatal woman. I've only ever seen puerperal psychosis once, and it was very, very frightening. I stayed with the woman until we were able to get her into the mental health facility. She wanted to kill herself, and she wanted to kill the baby, and she thought this was completely rational. It was the best option because she wasn't able to care for the baby as a mother. So these are the symptoms and signs of the life-threatening mental health conditions in the postnatal woman, and this is from the National Institute for Health and Clinical Excellence, the UK's NICE guidelines. Severe depression, such as feeling extreme unnecessary worry, anxiety, being unable to concentrate due to distraction from depressive feelings, severe anxiety, such as uncontrollable feelings of panic, being unable to cope or being obsessive, the desire to hurt yourself or hurt the baby, including thoughts about taking your own life and the baby's life, and confused and disturbed thoughts, which could include other people telling you that you are imagining things, becoming paranoid, having heard...
Sorry, Karen, to interrupt. We're just still stuck on well-being slide.
Oh, yeah, no, I'm just talking through this.
Oh, okay, right. So we are still on
no
the
slide. Okay, so there's no slide for this
okay,
in
cool.
this talk, but there is the slide around it in that 6-week check webinar. Okay, so I haven't put all of the slides from that 6-week check webinar in because I just did a selection of them. So if you want signs and symptoms of life-threatening mental health issues, go to the NICE guideline. They've got a very good guideline on it. And also I've the slide for this is on the 6-week check webinar. So it's very scary, but it's quite rare. Have you ever had puerperal psychosis, Bruce?
No, but I had a friend when I was at medical school who had a baby, and she became psychotic at the time. I don't know quite what the details were. It's extremely rare, but I think you're better, if you're worried, talk to maternal mental health.
Yeah, definitely.
Or a friend. I mean, you're probably as likely to see it amongst your friends. And
yes.
You know, so it is pretty rare, but postnatal blues is common, and some would say normal day 3 blues. That's very common.
Yeah.
It's a huge biopsychosocial tsunami having a baby, as I say.
Yeah.
Depression is about, I think it's about under 10%. I think it's about 5%, I think, in New Zealand, isn't it? At any one time.
Yes, yeah.
Different groups of women are going through. So it's not the same ones who are depressed at 6 weeks who will be the same. You know, there's quite a bit of interchange there. So it's something you have to watch. And I think as a good clinician, you should be on your toes for people's low mood. If you pick up a cue or their body language, you know, I think you need to be sensitive to that. Whether you're going to be a surgeon, you know, you still have to be, you still have to pay attention to those things, because having a true major depression, you've got the quality of life of somebody on renal dialysis. So people feel very ill and they're very poorly functioning. So be sensitive to those psychosocial cues. I think we could have a whole session on postnatal.
We could. We actually could. You know, we should do actually, because the next thing that I want to say is this. Now, as a country, we are appalling at child protection. We are probably the worst after the United States, which is never a good place to be in terms of child abuse and neglect, child maltreatment and neglect. And these statistics are horrendous, really. So, and if you think about a woman who, or like the case that I just talked about, who she wanted to kill the baby because she thought it was better for the baby that if she was going to die, then the baby died too. So that statistic about women are more likely to commit neonaticide, filicide, parental suicide, or fatal neglectful supervision that needs to be high on your list of concerns if you're picking up postnatal depression. And then these statistics are from the Family Violence Death Review Committees, and demonstrate, you know, the ethnicities that might be more likely to be victims. So read those reports if you want to delve into this more in more depth. But I agree, Bruce, I think we should do a webinar on maternal mental health and family health and family violence and our child protection statistics. All right, so we'll leave that because I'm looking at the time. We've only finished topic 1. So let's get on to topic 2, atopic dermatitis. So it's also known as eczema. I'm going to see if this works. It might not work, but this was just to put here. Can you hear that? Can you hear it, Bruce?
Not yet, no.
Okay. So this is just...
I could put in a link. I'll put in a link to it if you like.
Yeah. Okay, so this is Diana Purvis, And she is, you can see the picture, can you?
Can anyone else hear the sound there? I don't think I can't hear the sound.
But you can see the picture of Diana.
Yeah,
Yes,
I can't hear the sound. But
Yeah,
no, don't worry, I'm not going to do it. I don't think we've got time anyway.
Yeah.
So this is Diana Purvis. She's our country's expert on dermatology in both children and adults. She works at Starship Children's Hospital, and she's also in private practice. And she has run this seminar with me on allergy and eczema back in 2017. It's an excellent resource. It's a whole day seminar that you can access on the Pharmac Seminar Series website. And it has her talking about eczema, and it has Jan Sinclair talking about food allergy. Basically, when parents talk to you about eczema, and is it because of what they're eating, what you really want to emphasize is that it's a skin condition, eczema, and that we've got not enough information around food allergies, etc., to suggest that it's anything to do with food. So it's one of the most common chronic skin conditions worldwide. It affects up to 16% of children and 10% of adults. It's incurable and has significant psychosocial and economic impacts on affected individuals. So in terms of treatment, it's really important to get it right. Okay, so now I can't get on to the next.
I'll just make a comment. If you have a look on the Pharmac Seminar Series website, there's a whole lot of videos there you might like to look at. They're
Definitely.
all free. I used to be one of the organizers for that. All the talks are fantastic. We only used to get really good speakers along, and there's a lot of material there, very relevant to doctors in training. So a place to, I'll be sending out a link to some of these things through the teaching coordinators. So including the Ashley YouTube video, which I've just it's from Jordan Mooney. It's called Corona Kiwi Ken Doll, as of Ken and Barbie, for those of you who know about Ken and Barbie dolls.
Yeah. They've just had a whole load of wedding photos, Ken and Barbie, on Facebook, I've seen.
They're still alive and well, I think. Ken.
Yes. Okay, so watch that clip. You can watch little clips. So I wanted to just illustrate, Diana was looking at the pathogenesis of eczema. So this slide demonstrates a beautiful normal skin with your corneocytes as the epidermal layer, and then underneath that you've got your lipid and your moisture layers. And what happens is that the bricks, so the house on the left, as you look at it, the bricks start to crumble, the moisture starts to leak out, and you get severe eczema, and it's a very unpleasant condition. So it's been used, this analogy of the bricks of a house has been used by famous people in the UK, and Diana uses it as an analogy. So you want the house on the right, that's what you want your skin to look like, with the bricks. And what they've found recently is this protein called filaggrin. And filaggrin comes from filament aggregating protein. And it binds to keratin fibers in the epithelial cells. And filaggrin deficiency is caused by a genetic mutation on chromosome 1. And it's present in about 8 to 10% of the population. So these people's skin does not retain water well. And that's the basic treatment of eczema, is you've got to get the moisture back in the skin and get the bricks back to the correct shape. So the filaggrin protein helps the bricks to be the correct shape. And it's got a role in maintaining the lipid layer, that moisturizing layer. It maintains the pH of the skin, so the skin doesn't break down and become infected. And what they've found, that people with eczema have 3 to 4 times an increased risk of eczema if they've got low levels of this filaggrin. And and as well, very interestingly, the research is being done at the moment that the low levels of this protein is associated with peanut allergy too. So when the skin lacks the protein, its ability to shield against external dirt and substances is reduced. So you have to explain to parents that it's a condition of childhood, usually early childhood, that you can't cure, but you've just got to treat the symptoms. Most important things are you don't use drying factors on the skin. So you don't use soap, you don't use bubble bath or baby, lovely perfumed baby oils in their bath, and you don't use perfume. And this probably goes against what you would think, but you need to bath or shower every day and use non-soap products as the soap. So you use the moisturizer and non-soap products as the soap, and you spend about 10 to 15 minutes in the bath. And if you've got severe eczema, it's really good to have bleach baths twice weekly, because that reduces the staphylococcal load on the skin, which is what creates the infections. And if you want the information around bleach baths, these resources, I've put a slide in with the resources, Bruce, but the different sorts of bleach baths and why you use bleach is on the pediatrics. It's on the Kids Health website.
I'll send out a PDF of Karen's slides. One of the things I say to patients, just so they get a clear message about that soap is the enemy of the skin, but it's okay for your hands and bottom. So there's two parts of the body and perhaps the axilla, but anywhere else, I think soap is and it's interesting with teenagers with acne, they start throwing soap at their face, and because it's an inflammatory condition, they just make it worse. So I don't know if you'd agree with that. Soap for hands and bottom, the rest of it.
Well, definitely soap for hands at the moment.
Yeah, absolutely. So, soap's the enemy for eczema. And it often is the first place that people go, isn't it? They sort of think it's,
Yes, yeah, that's right. So people can get quite anxious about using bleach, but it's okay as long as you use these bleaches. You don't want to use Genola because that's got all sorts of other things in it other than just bleach. The cheapest bleach is the best, but these are the ones that are recommended in this slide here.
Got a question. So, if low levels of filaggrin associated with peanut allergy, at what point would you want to refer a patient with recurrent eczema to immunology? And I guess, I don't know if you're going to talk about doing the skin test. You're coming? Is that in the...
No, because I'm not covering food allergy. That's another one we could do at a different
we could have you here forever, Karen. We'll get you back to Auckland University ASAP.
So what we want to do is restore the skin's integrity, and we do that with moisturizing creams. You cannot emphasize how important it is that they use the moisturizing cream. So if you've got a baby with eczema or dried skin, is what I always say to them, every nappy change, lather them with the cream. And it's not so difficult when they're little. It gets more difficult as they get bigger and more stroppy, and you can't manage to get the cream on them. But this is the fundamental basis of treatment of eczema. Moisturize, moisturize, moisturize. Now, if the skin, just some facts. Increased emollient is associated with improved eczema, reduced corticosteroid use. You want to reduce the contamination of emollients. So I always use the one in the middle, the Health Sorbolene cream with the pump pack. So then you're not having people put their dirty fingers into their tubs. What you can do is suggest that they use spatulas to get the cream out of the tub, so they're not putting their hands in the tubs. If they do prefer creams, the non-ionic cream rather than the Sorbolene cream. The aim is 500 grams every 2 to 3 weeks. So that's a whole bottle every 2 weeks you should be using, or a whole tub. You reduce the cost burden. So we can do this for under 13-year-olds, 13 and unders, because it's subsidized and it's free. Continue moisturizing even when there's no active eczema, and the personal and family preference is that some people don't like sorbeline cream, some people don't like fatty cream, so you use the cream, you get them to use creams that they want to use, otherwise they won't use them.
Karen, do you want to make a comment about some of the perfume moisturizers you can buy at the pharmacy? I generally discourage people.
Yeah, absolutely. Don't use them. Yeah, don't use them. I mean, the one Aveeno is really good, but I think we can, and it's expensive though. We can use we can use these creams for children, and they can get them for free, and then that will hopefully encourage them to use the frequency that we suggest, which is 500 grams every 2 weeks.
Sometimes adults don't like them from the cosmetic point of view. You know, the fatty cream can be sticky for a while. So
yeah,
very occasionally I do suggest, if people have got the money, is Cetaphil, because it dries
yeah,
quickly. But that's a pretty expensive option. Although at the chemist warehouse they're relatively cheap. But in general, for the young kids and prescription, these young families are in a lot of financial trouble, and you've really got to not put any costs on people. You've got to think about that every time you pick up that prescription pen. Make sure, in fact, if there's ever a part charge, I say to patients, there's a part charge. Is that an issue for you?
Yeah,
just check it out.
I agree.
Nice way to say it. It's not saying, you know, can you afford it? Is that an issue for you?
Yeah.
Even a $3 or $4 part charge will be too much for some families. They'll go without food. So something to think about.
It's very important. I completely agree with you, Bruce. I think it, you know, as training doctors, I think it's really important that you always consider these factors when prescribing, and become a rational prescriber. You know, don't just write prescriptions because you can. Write them if they're needed and necessary, and think about the family situation.
Just to let the audience know, we're going to go to 12:30. If we don't get through this, we'll get Karen back to finish it off. So this is such a good topic, Karen. It's terrific. Carry on.
Okay, so some families get very concerned about steroid cream. Now, when you think of the bricks, right? So once the bricks have started to crumble and the moisture is coming out of the through the cornea sites, what you've got to do is you've got to get the integrity of the skin back, and you do that with steroids. So it's much better to use steroids appropriately and not sparingly. We used to say for a long time, oh, apply sparingly, and I think that's what's got the message out to the general public, that steroids are something to be very frightened of. They're not at all, as long as you're not using them for extensive lengths of time. And this is why it's important to emphasize that for a short period of time, but you must moisturize, because it's the moisturizing that, once the skin's integrity has been restored, it's keeping that moisture in the skin that will stop the skin from breaking down again. So with babies, you wouldn't use these stronger steroids on their face, but you can use them on their bodies for 2 weeks maximum. The issue, of course, is that steroids, people worry about steroids and the systemic absorption of them that could impair growth or create issues with the adrenals, etc. Not if you use them in short periods of time. And Diana talks at length about the use of steroids, both on the Kids Health website, and also on that Pharmac seminar series. Right, so you want to apply the steroids 2 to 3 times a day on the skin, and make sure that the skin glistens when you put the cream on. You put the steroid cream on after the bath, and you put the cream on and you wait half an hour, and then you put the moisturizing cream on. So the goal
is the issue of creams versus ointments. I was always taught you put ointments on very dry lesions.
Dry lesions, yeah. I've got that on in the slide here. Yeah.
Okay, good.
Yeah. So creams are easy to apply. When Bruce was talking about some people don't like fatty cream, we do, the Sorboline does have glycerin in it, so that makes it a little less difficult to apply. So the goal of steroid use is to reduce inflammation during acute exacerbations. Once the skin's integrity has been restored, there's no need to continue with the steroids. But you must continue with the moisturizing cream, remembering that it is a chronic condition, you can't cure it. It's safe and effective to use steroids. You apply to all areas, even if it's infected. You apply the steroid cream to the infected areas too, because if the skin is infected, you are giving antibiotics as well. And yeah, apply so the shiny thin layer can be seen on the skin, and you can read the rest of those. We've just gone through that. Lotions are easier to apply if they've got very dry skin, eczema in the scalp.
Just a question here, and I was just going to make a comment about the scalp lotions are all fairly potent steroids, but the scalp is a different area from the face. You can use potent steroids on the scalp, but be very careful about
of the face, especially
use
around the eyes.
Yeah, the eyelids is the only place where even hydrocortisone can cause damage. Yeah. So that's something to be aware of. Question about when using steroids, do we use them over the whole body or just the active lesions? Just the active lesions, I would say.
Yeah, yeah.
Okay.
If you think about what the rationale for using them is, and you think about that analogy of the bricks, you want the bricks to be restored. So once the bricks are restored and the skin looks healthy again, then there's no need to use steroids. And my advice is always, you don't use it longer than for 2 weeks. And with little children, I bring them back to see that the skin is repairing. It can be very distressing eczema, especially severe eczema. Again, this is where practice nurses are invaluable. We have a nurse-led eczema clinic at our clinic at Greenstone, along with a nurse-led asthma clinic. This is the eczema management plan. Every child should have an eczema management plan if they've got eczema. It's easy to follow, it's pictorial, and you can explain it to the parent of this is what you've got to do. You can get this off the Kids Health website, this eczema management plan. Okay, so just some key points here. Almost 30% of children will report having had eczema at some point. So that is an awful lot of children, 1 in 3 nearly. And this is interesting, and this is reassuring for parents. So more than half of them will grow out of it by the age of 6. Children with eczema benefit from regular recall, review, family education and preventative care, and nurses can do that perfectly. And eczema is an equity issue. And as Bruce says, you know, in equity issues, you've got to think about people who aren't as rich, and that you do everything you can to make sure that they get the treatment, the correct treatment. Oh, it's freezing. Go. Oh dear, Bruce.
I'm not sure whether.
Oh, no, there we go. I'm all right. Sorry.
I was doing something in the background. I didn't realize I had power and control.
No. Have you got power and control? Okay.
I think so.
Just before we leave eczema, I wanted to say this is a red flag. This is a get the child to hospital immediately. It's life-threatening. Eczema herpeticum. You won't see it very often. It's a disseminated viral infection characterized by fever and clusters of itchy or blisters, punched out erosions. This is what it looks like. The child will be sick, the child will be unwell. It's a red flag. It's also known as Kaposi varicella eruption because it was initially described by Kaposi in 1887, and you'll know Kaposi from Kaposi's sarcoma in HIV patients. It arises in a first episode of infection with herpes simplex virus. So the good advice to parents is don't let people kiss your baby. People, particularly with cold sores, you definitely don't want them anywhere near your baby, because that's where they get infections like this from. The signs appear 5 to 12 days after contact with an infected individual with herpes simplex.
So Karen, I'm just wondering whether there'd be a natural
oh yes, stop. Yeah, we could stop now.
We're going to have to get you back next week if you're willing to do that.
Should we do cases next week, and I'll just go through spotting the sick child then?
Okay, I think the audience would really appreciate that, because I think we're all terrified of the sick child, because it's often a needle in a haystack, but it's a disaster if you miss one. So we'll finish up after that, eh?
Yeah, definitely. Yeah.
If you're okay to come back next week, I think that would be excellent.
We probably don't need an hour and a half next week with the cases, do we?
We could probably do some other stuff as well. We can figure that out in the meantime. By the way, the other thing, I will send out a list of links. The other one I was thinking about is Health Navigator. I don't know how much people know about it. Health Navigator's got a lot, it's got stuff on everything, tons of good stuff. And I think, I haven't looked at the postnatal depression stuff, but there's stuff there for patients and there's stuff there for health practitioners. It's a wonderful website. It's a New Zealand website. It's all localized. It's all up to date. It's like DermNet. It's an 8th or 9th wonder of the world.
Also, Bruce, Auckland Health Pathways, which if you've got the password and username, you can access anywhere in the country.
Yeah, I think the students know about that. It's connected as the username, and the password is healthcare. And as Auckland students, doctors in training, you're eligible to use it. I think most of the doctors in training are getting used to using that. Another great resource, and it's very much what we expect you to know, and it's localized. It's for the Auckland region in terms of resources. Carry on.
So there's just a couple of resources, and those resources will lead to further resources if you're interested in this topic. Okay, so do you want to have a stretch, everybody, before we go into the final leg?
Stand up and exercise your core.
You've all been doing Les Mills, body balance. Yeah.
I did try Les Mills, but it was a bit much for me.
Yeah, no, I like his yoga. I like the yoga one, the yoga something. Because they do a nice 15-minute of relaxation at the end of it. I have to say, my neck has been particularly bad working from home. So I got a new chair yesterday. And that's it. I had to put it together. That was the only thing.
Okay.
Okay, topic 3, spotting the sick child. Everybody had a stretch? Now, I cannot emphasize enough, and I tell all the medical students and all the nursing and nurse practitioner students, you must register for this website. It's a UK resource. It was developed following our epidemic of meningococcal disease at the turn of this century. So in 2000, we had an epidemic of meningococcal C. And so this resource was made into DVDs, and every health practitioner who dealt with children got a free copy. They then put it onto the website, and they've just carried on developing it. It's free to register, and it's got the basic how to do the 3-minute toolkit. I was trying to get it up so I could show it to you. All of our rooms at Greenstone Family Clinic have the 3-minute toolkit as an aid memoir on the wall. It's got the 3-minute toolkit, the basis of basic child assessment, and it's got 8 symptoms that children commonly present to primary care and emergency departments with. So you can work through each of those 8 symptoms and feel really confident that you are not going to miss anything in terms of serious childhood illness. Wonderful resource, and I can't emphasize. So detecting serious illness, if you have a systematic, and this is the 3-minute toolkit, if you have a systematic way of assessing a child that includes the physiological signs, you will not miss serious illness. What you do need to do is to ensure that you've given all of the anticipatory guidance around what to do if the child deteriorates. So if you see a child and you take its breathing rate, you do its SATs to make sure that its SATs are within normal limits. And if you want to look at what the different physiological signs are for each age, it's on that website, but it's also in the NICE guidance for managing feverish illness in children less than 5 years old. Always take parental reports of fever seriously. That's in the NICE guidelines. Use an electronic thermometer, axilla, if they're less than 4 weeks. And if they're 4 weeks to 5 years, we usually use the red tympanic thermometers. So you always measure and record temperature, pulse, respiration, and capillary refill time, central capillary refill time. So that's pressing on the sternum, going 1 and 2 and 3 and 4 and 5, and then taking your finger away, and the skin should return to a normal colour in less than 3 seconds. So you're assessing for signs of dehydration. So a prolonged CRT, more than 3 seconds, is an orange sign for worry. A weak pulse and a fast pulse, tachycardia, is also a sign of dehydration. Abnormal skin turgor, abnormal respiratory pattern, and cool extremities. And then I'll put in D, E, F, G. I can't do a question and answer, but that is, don't ever forget glucose. There's a really good Pharmax seminar day with Craig Jeffries, who's the endocrinologist from Starship. And something like 50% of type 1 diabetes children present to primary care, but they're not picked up because they haven't had a urine test done. They've had strange symptoms that don't, so they're repeated offenders in primary care, and people don't always, people do forget to think about type 1 diabetes. So they end up being seriously ill with diabetic ketoacidosis. So do watch that seminar. It's excellent around endocrinology. So fever is not the enemy, and that's really important to stress to parents. Parents will come to see you and they'll be really anxious because of the baby's got a fever, right? So you've got to dispel the myths of fever. A study in the USA in the 1980s confirmed that parents had numerous misconceptions about fever, and their unrealistic expectations or concerns were termed fever phobia. So it became a thing. And 20 years later, in the early 2000s, they did a further study to see if anything had changed over the 20 years. And this study demonstrated that fever phobia persists, and I certainly anecdotally know that parents get really worried about high fevers. That 56% of carers were very worried if a child had a temperature. 7% thought that fever could rise to above 43 degrees if untreated. 44% considered 38.9 to be a high fever, and 91% believed fever would cause harmful effects such as brain damage and death. And 52% would check the temperature at less than 1 hourly interviews, and most worryingly, 44% gave either ibuprofen or paracetamol at much more frequent intervals than is recommended or safe. And if you think that paracetamol is the most dangerous medicine that you can buy at the supermarket that you can give to children, it's really important to emphasize that you aren't treating a fever in a child. What you treat with paracetamol, you don't want to treat a fever with paracetamol or ibuprofen. What you want to do is to treat misery, and you give them paracetamol or ibuprofen if they're miserable and unhappy. If they've got a fever and they're playing and running around, there's no need to prescribe paracetamol or ibuprofen. So fever is not the enemy. Remember that. What is the enemy is tachycardia and dehydration. So very often in our practice, if we get miserable children coming in and you can really concern because they've got a CRT of more than 3 and they're very miserable, and you spend some time and you give them some paracetamol because they're miserable, and you spend some time rehydrating them with Pediatric frequently with the parent there, I have numerous times seen them perk up within a half an hour, and not needed assessment by a paediatrician. So these are the signs of serious illness. Teach parents the signs of serious illness and make sure that they've heard you and that they can tell you back what it would be that they would bring them back to see you if they were concerned. So the first thing, the picture demonstrates the glass test, and that is the test to look for a non-blanching rash, which is the really concerning sign in septicemia, meningococcal septicemia particularly. You can do this without a glass. You can do this test by stretching the skin, and if the rash goes, it's a blanching rash. If it doesn't go, it's a non-blanching rash, and it indicates petechial spots under the skin. Nasal flaring, indrawing, grunting, increased work of breathing, and skin turgor, which you can assess by looking at the skin, but also by the CRT. Teach parents the signs of serious illness. That's it. We'll do topic 4 next week. And it's 25 past, so we've left some time for, do you want to know what the answer is to the...
Anyone get the virtual chocolate fish? And could you just send in questions and I'll ask Karen. We'll go through for another 5 or so minutes. And if you've got topics you'd like us to cover for future, so we're going to call these the Thursday morning tutorials. If you've got topics you'd like us to cover, primary care topics, then send us in a question. That would be good. What if they have a history of febrile seizures? Would paracetamol be necessary then?
No. Only if they were miserable. Okay. That's the rule. Paracetamol does not stop febrile seizures, and neither does febrile seizures are not indicative of the extent of the temperature either. They think it's to do with the rise. So, you know, if you've got a child with a temperature of 37.5 that goes up to 38.5, that wouldn't necessarily be classed as a high temperature, but it could be that they have a febrile convulsion.
I just go back to that glass and the blanching, non-blanching. It's the non-blanching rash you worry about. Is that right?
Yeah. So you expect the rash to go when you when you stretch the skin, or you put the glass over the skin and press. You expect the rash to go. That's a blanching rash. That's okay. You teach the parents this, and you tell them that if they ever saw the non-blanching rash, then they need to seek medical help immediately. And whether that's you're nearer as a general practice, or they're nearer to the general practice, or whether they just go straight to hospital, because that is this, you know, within I've diagnosed a meningococcal septicemia, and it was incredibly scary how fast. So the child had a tiny purpuric spot on the bottom of his foot. And that's the other thing that I think is really important with pediatrics, is if they've got illness, you want to make sure that they've got a rash nowhere, and you look complete, especially if they're little, you completely strip them off and you look all over the body to make sure they've got no rashes. The meningococcal septicemia I picked up was a little purpuric spot on the bottom of this child's foot, who was quite unwell. He was my friend's son. And I said, that's a mole. We got the older boy's torch and magnifying glass. And when I looked at it, I could see it wasn't actually a mole. It was a purpuric spot, quite a large one. So I rang my husband, a paediatrician, and said, "Ooh, what should I do here?" And he said, "Well, one spot's not going to do anything particularly." But in the middle of the phone call, the pinprick spots started to appear on this boy's neck. And I just said, "Get this boy to hospital now." Within half an hour, by the time he got to hospital, he was completely covered in the rash, head to toe, half an hour. And it was 24 hours before we knew whether he was going to live or die, that little boy. And that was in the middle of that meningococcal C epidemic I was talking about.
Was that in the UK? Because we had a big...
Yeah, it was in the UK in 2000, in the year 2000.
Because we had the meningococcal B around that time in New Zealand. So
yes.
a question here, could you ask the chocolate fish question? And then I've got a couple of questions about blanching, non-blanching rashes.
Okay, so what are the three initiatives that have globally saved children's lives? Have we got any answers? I gave you a hint for one. Bruce, shall I look at the question? You've got the chat.
Oh, it is. I'm getting a bit mixed up with.
All right. Oh, shall I just tell people and they can give themselves?
We didn't want to have a go at the chocolate fish. We've got oral rehydration therapy and vaccines.
Okay, so nearly. I'll tell you what they are. They're clean water, immunisations, and antibiotics, and that's WHO evidence-based, most global effective initiatives to reduce child mortality.
Okay, we had vitamin A rice, incubators, Peppy Pod, safe sleeping. I'm not sure if these are questions for, we've confused the audience, I think.
Yes, the chocolate fish.
HC gets the chocolate fish because she got vaccines. So
good.
Yeah. Okay.
They are the most evidence-based initiatives. So, well, I think, Bruce, it'd be just worth saying to these trainee doctors that when you have the discussion, if people start to discuss being anti-vaxxers, then it's best to just say, I'm not discussing it because this is the evidence base. And if you enter into a conversation around anti-vaccination, you then are giving legitimacy to a bit like being the flat earth. I think Nigel Latter says you wouldn't kind of start having a debate with flat earthers. And IMAT, which is the Immunisation Advisory Centre, we've got some really good resources about how to address or how to not address anti-vaccination, because there's 5% of people in the country that won't want to vaccinate their children, and you're not going to persuade them or otherwise. There's no point getting into a conversation about it.
Okay, we do have another chocolate fish here. MY got vaccines, safe food and water, and breastfeeding, which I think is pretty good.
Yeah, well done. Don't forget antibiotics though. Antibiotics used appropriately in community-acquired pneumonia in the developing world save lives.
Yeah. Okay, well, I'll stop recording now. We'll go on to answering some questions about blanching if you want to stay. And I'd just like to thank Karen. I think that was absolutely terrific, Karen. and we'll have you back next week. If you want to send in some questions for other topics, please do. We're going to stop recording now. Okay, and
Bruce